All right, the second topic, as Amy alluded to, is outcomes-driven payment. And really what we're talking about is outcome-driven payment really defines how we pay for the care. The main feature is that it ties payment or an enhanced payment either to the MCOs or to the service providers to specific quality or cost factors. It goes beyond what we consider the typical fee-for-service. For example, some of the common approaches that we see are paying providers more for meeting performance targets, whatever those targets might be, we can develop those. Episode-based payments, where a provider is rewarded for taking care of an episode, such as an acute asthma, in ways that are more successful clinically and also more cost-effective. And then we have population-based care, so the provider takes on responsibility for all the care to that particular member, not just the care that that provider provides. An example, a pay-for-performance for plan in Iowa. This really plan, I'm not going to read through all these, but you can kind of get the context of kind of what this would be. You know, this plan focuses on patients with multiple chronic diseases. The primary care physicians or the PCPs receive tiered per member per month based on the number of chronic conditions. So for example, I believe the primary care providers in Iowa there, they get $12.80 additional for individuals with 1 to 3 chronic conditions, and all the way up to $76.81 for individuals with 10 or more chronic conditions. And the providers can earn a bonus based on performance benchmarks, really in 4 areas is what they have. So, you know, preventive care. So are they focusing on the prevention of those? How are they treating those chronic illnesses? You know, and mental health as well as adult or pediatric specific chronic type measures. So those are additional payments made based on an outcome, not just providing a service and getting a fee for that service. Another example would be an episode-based payment. So example for asthma. It really includes the cost to take care of that individual, that entire episode for a period of 30 days. You know, it would include hospital admissions, readmissions, any post-acute care. So that's what we refer to episode-based payments. Population-based payment model. You've got the primary care doctor contracting for care of patients. You know, they take on that responsibility for a vast majority of all that health care provided to that particular patient. It really often includes acute care, you know, the chronic conditions that we talked about, and really certain behavioral health outcomes. And the risk is shared by the payer and the provider. If the costs for the population go down, the provider can share in those cost savings. If they go up, then they share that risk as well. There's upside and downside protection or risk for each of those provider types. Last, we have population-based outcomes. Again, it's really the ability to share some of those savings or increase cost. Most of these models really reward providers at a higher rate if they reduce the cost, directly related to some specific health outcomes for those patients. Models often penalize providers that drive down costs too much to show poor health outcomes, and they do not reward providers that withhold care to drive down those costs. So there are mechanisms built into place in that process to ensure that doesn't happen. So again, for this tabletop exercise, some questions we'd like you to consider. You know, what provider types or groups should be considered first? So should we focus on behavioral health providers? Should we focus on primary care physicians? Should we focus on HCBS providers? So that's what we're looking for with this particular first question. Are there specific diagnoses or conditions, chronic conditions or procedures even, that we would want to focus on first to be considered? And then really, what results should be rewarded? Amy.
All right, thanks, Mike. So this is your opportunity to put on your healthcare finance expertise hat and share a little bit about what you think KanCare should do regarding reimbursing providers for the services provided. So this is a potential change being considered. You have about 10 minutes to talk at your tables. You can address these questions or the questions on your blue sheet. We're going to start with the 4th row, and we're going to hear from each table in the 4th row, the 5th row, the 6th row, and the 7th row, okay? That'll be about the middle third-ish of our room. And we're going to get some good input now on outcomes-driven payment. So the 2 questions are the same. What question did you discuss? And share one thing that you talked about in response to that question. So how about this back table?
Okay. We looked at what provider types or groups should be considered first. And as we talked about it, we felt like that shouldn't even be on this questions because it should be individualized and prioritized to the needs of the services for each individual person.
Okay.
For an insurance group to be able to make those decisions, that is not wrong. And what results should be rewarded would be, why should they? They're doing the things to be normal.
Okay. So let me make sure I caught your first one. So the first one is that this question isn't relevant. The first question isn't relevant because you think it should be based on the individual's needs and that the provider shouldn't be the priority but the individual. Did I capture that? And the second one was you asked about, you talked about what results should be rewarded. And what was your answer there?
The results is the insurance company shouldn't be rewarded because they're doing what's supposed to be happening to begin with. There's a 3-day time rule normally in hospitals where they have to get them in and get them out. If they're doing their work, then that's fine. If they're not, then why are they being rewarded for bad practice?
So the reward would be going to the provider. So in your example, that's the hospital. And so what should the hospital be rewarded for doing in your case or in your example?
They're not.
You don't think they
not.
should be rewarded?
Okay.
Okay.
Because they're kicking them out. They're kicking them out too soon.
But what if the reward was like if you successfully healed the issue in a certain time frame? Should that be rewarded? No.
That's not the issue.
Okay, so what is the issue?
Just quickly. I don't think they.
I can hear you.
I don't-
Just talk up a little bit. Although I can't hear
I'm
you.
not
Other
sure.
people
There,
are
my mic's
talking.
good now. I don't think they should get a reward. And I'm talking about like a time frame, like this 3-day business about getting people in and out. I'm a nurse. It scares me to send people home after that 3 days. But I haven't got a really, really, really big issue. I just know they don't have a caregiver. I know they don't know their meds right. There should. But that reward is whatever, a monetary maybe, that okay, good, you're going to get to stay in the program and take care of our Medicare and Medicaid people because you got everybody out in 3 days. Baloney.
Okay.
They-
Well, thank you
yeah.
so much for answering my additional questions. I just wanted to make sure I understood what your table had talked about. So thank you for that. Okay, next table. Tell me what question you talked about and what one thing that you responded to.
We actually discussed all 3 of those questions that's up on your board there.
Could you put the microphone a little
sorry.
bit closer to your mouth?
We
Thank you.
actually discussed all those 3 questions that's up on your board, and kind of ditto. We really felt like those were, for lack of better terms, inappropriate questions when you're dealing with a person.
Okay.
Just
All
to
right.
add, and I'm speaking from experience. You know, I've worked in a hospital setting, and I've worked in a long-term care community setting. And when the state started coming in saying, okay, you have this criteria, and you're going to be paid per what this individual's diagnoses are, et cetera, what I saw changing within that organization, we stopped serving a person, we started serving a billing source. And plans started getting created to bring in more money to the organization. So I think you're going to lose individualism. I think you're going to lose actually person-served driven, and I think quality of care will go down.
Okay.
So those 3 questions, not to insult whoever created them, I just think there's better ways of kind of getting to maybe what you're wanting, and we weren't sure really what you wanted.
Okay. Well, thank you so much for that helpful input. And I hear lots of agreement in the room for these ideas that serving the person is the most important thing. What's the next table, and what question did you address, and what response did you have? I think they're going to pass.
They are going to pass.
Okay, so the
So, Ann, you're
4th
next.
table. Hello.
Hello.
Put the microphone really close to your mouth.
What results should be rewarded? Our answer was a feeling of peace from not having to worry about their health conditions anymore and enjoy life more than they did before.
Oh, what a beautifully poetic answer.
And-
Thank you.
I'm talking from experience. My wife has been in life care for 3 years now, and she has Alzheimer's. There's no cure for it, but the care she's getting and the feeling of relaxation that I have by life care taking care of her gives me quite a bit of peace.
Oh, thank you for sharing your story. So a sense of peace, not having to worry, and needs being taken care of. Thank you. That is the result that you want to see rewarded.
Well, I would like to say congratulations to the caregiver here whose wife is getting Alzheimer's care. I'm actually a provider of memory care and dementia care in assisted living. But I'm speaking for the group of that's here at my table.
And what question did you get a chance to
We
talk
took
about?
question number 1, what provider type, and we chose the family practice group of physicians, specifically because of a personal experience with a seizure disorder, and the complication in retrieving the medications the child needs. They're delayed. She can't get the medications to her home in time, and the child has a seizure, ends up in the emergency room. So there's no meds available, even though, they should be there on time. The other concern from another chronic illness is in regards to preventative testing that the physician recommends, and they're supposed to be getting some kind of points on an OTC card, and the provider, the physician, is getting rewarded for getting his patients to get preventative care, but the points are not showing up on their OTC card.
So making sure that whatever gets back to the consumer, they're supposed to get back to the consumer, actually does get back there.
Correct.
So thank you for sharing that thought that primary care physician should be the first type to be focused on. All right, thank you. How about the next table? What question did you discuss?
We discussed what the state should keep in mind as they're considering payment reform.
Great.
And we thought the most important thing is that quality care means the provider developing a good relationship with the client, and that takes time.
Great. So focusing on that relationship between the provider and client and allowing time for that relationship to develop.
Yes, ma'am.
Oh, thank you. Thanks for that helpful input. All right, next table. What question did you talk about?
Okay. We agreed with the first 2 tables that the first 2 questions are really inappropriate, but if you guys decided to do that, who would end up making that decision was our
So maybe a
input.
question for the state to consider as they go forward is who is responsible for making these types of decisions?
Yes.
Okay. And you would be interested in knowing who that is, or?
Yeah.
Okay, great. Thank you. All right. Last table in the second row. What question did you get a chance to discuss?
We looked at the first question, and we pointed out that we felt like the PCPs need to be looked at, because if they're going to be providing preventative care that equals out to positive outcomes, then they should be rewarded. But if they're not going to follow through and take care of quality of life issues and give that person a quality of life, then they do need to be penalized.
Okay.
So often our PCPs have themselves up on a pedestal that think that they should not be questioned, and they're not taking the time with the patients to explain why they're doing certain things. People that live out in the community, people that go to their doctor's offices, they might take a few extra minutes to explain something, but people that are in the nursing homes are not getting those exclamations. They should be told that that there is no longer any test or any medications that can help them. I've had clients that have been put on hospice and never told by the primary care physician or even by the nursing home. I, as their guardian or conservator, have had to go in and tell them that.
Okay. So focus first on the primary care physician, and also I heard quality of life issues, making sure that somebody's quality of life is high, and that's what should be rewarded. Thank you. Okay, we've got 2 more rows of tables to go here. So at the next table.
Okay. We are speaking from a recipient's point of view.
Great.
It seems like these questions are made for providers. And we wanted to mention that for the first question, that because of the reimbursement rates, fewer and fewer doctors are accepting our patients.
Okay. Thanks for sharing
Something
that
has to
concern.
be done about that.
So that's definitely something for the state to keep in mind, that the number of doctors accepting KanCare seems to you to be reducing, and you want to make sure that there's doctors available that you want to see. Okay.
Absolutely.
Awesome, thank you. Good input. All right, next table. What question did you discuss?
We discussed all three of those specifically, but one that I think we all agreed was which diagnoses, condition or procedures. I think one of the things that we're most concerned about is that we're not giving the physician the power to make the decisions outside of the insurance company. The insurance company is kind of dictating, and that is not a fair exchange of education. The person on the other line does not have the education that the physician does, and that needs to be something that's addressed. But the other concern that we have is that if that does continue to be a problem, those physicians are going to start refusing to see the patients. They're going to be refusing to see anyone that sits under Medicaid or Medicare, and those patients are going to be out that physician's expertise.
Okay,
and we
so you
don't
wanna
want to see that.
You want to make sure the physician's expertise is considered in the
Absolutely.
provider reimbursement process.
Absolutely.
Okay, thank you. Good input. All right, next table.
I realize that everyone sees the questions through a different lens, and my particular lens is primary care. And when it comes to population health, what we see is an epidemic in type 2 diabetes, particularly in younger children. And so we certainly believe that that needs to be a focus in terms of question 2. But the caveat to that is we began to see some significant positive results when we had the Health Home Initiative in place, where case managers were dealing with each patient individually, respecting their dignity, and helping them navigate the system to receive the services they need. And so my recommendation would be, along with focusing on diabetes, to make sure that there's a case management component so that people that need assistance in navigating the system will have it.
Thank you so much. So I hear, in response to which diagnoses, conditions, or procedures, I hear type 2 diabetes, and I hear also support for the health home model. Thank you. Okay, this table's passing. How about this next table?
The question is, what results should be rewarded? And we feel that any reward to the provider must focus on the customer, leave no room to game the system like the VA has done, and at the detriment of the consumer.
Great. So making sure that focus is on the consumer and not giving providers any chance to game the system. Thank you. Okay, next table.
We want to kind of piggyback on what he said. The problem with the result-based as opposed to the fees-based, as we've seen in HMOs that's outside of the Medicare system, and we're dealing with regular insurance, was unfortunately, we have some excellent primary care physicians, but unfortunately we also have some primary care physicians that found it very profitable to reduce a lot of the normal procedures and still actually make more money because they paid a certain amount. So if you go to the result-based, who decides whether the results were obtained? Is that the physician decides it, the provider, or not necessarily the physician? If it's the provider that decides it, isn't that a little bit of a conflict of interest? You're kind of writing your own grade card. And why is it always tied to the insurance? What about, again, the individual? Especially when you're talking about these chronic illnesses, how do you grade? Let's say it's a little bit easier with diabetes. Oh, we're not going into the emergency room all the time with ketoacidosis or seizures. People are not running in there because they're not keeping those under control. But it's a little bit harder when you're dealing with like mental illness, and you were talking about the behavioral problems. How do you those results?
So figuring out how to measure results, and then also I hear wanting to make sure that the provider isn't necessarily the one determining what the results are, worrying that some providers might be motivated to drive down costs at the detriment of care.
Yeah, we
Okay.
saw that in HMOs. We had primary care physicians that literally ignored patients and told them, you do not have a problem. This is
Right.
really not a problem. You don't need
So you want to
this
make sure
X,
that
Y, or
the
Z.
pieces are in place, that there's not that motivation.
Right. But then
Okay.
it's the insurance sides too, because they're looking at keeping the costs down at the same time. So if those two are the ones that are deciding everything, how is it when you talk about it being results-based?
Okay.
It's a
Good
very
questions.
difficult thing to put a monetary value to.
Good questions. Okay, we have 3 more tables to go this round. What question did this table discuss?
This table has heard all of their discussion and their
Okay.
comments.
All right.
This table, on the other hand, has a comment to add.
Great.
We talked about everything, but our topic came from which diagnosis, conditions, and procedures should be considered first. One thing we definitely said is that all of the MCOs should be consistent in the way they're paying and doing things and services, because right now, for instance, we all come from a different background. In mental health, each company has to process things different and does not pay the same. So when they do this, if you're talking diagnosis and conditions, all the MCOs should be across the board the same. So that way all providers get paid.
Okay, thanks for that input. So hearing value for similarity across MCOs. Okay, last table for this call out.
We talked about the results should be rewarded, and a concern we had was we support having the primary caregiver. It's good to have someone that knows the whole case. But if you're rewarding a provider for treating someone with multiple chronic, are they going to be willing to refer them on to a specialist that could better care for that person? So I have a child that they could have been playing with medicine for a long time, and my son would have got a lot sicker if he wouldn't have been immediately sent on to a specialist. So that concerned me.
Okay, so making sure that a primary care physician isn't motivated to keep a patient rather than referring them on, and making sure that specialty care is available. Okay. Hey, you guys, good thoughts. You are doing good work and having great conversations, and we really appreciate all of this good feedback. So that is the end of our input for the second topic. I'm going to invite Mike up to talk about our third topic today.